therapist, and I've worked at mental health centers. I've worked in child welfare. I've been at CKF for 10 years and started as a therapist here and a group counselor and have worked my way up. So I've been in this position the last 2.5 years. Some really exciting things happening at CKF. So I'll share some of that with you as we talk about understanding and accessing addiction treatment. What is this system of care and how do we really connect people to it who need this important healthcare service? And navigating that along the way can be tricky for people. So I want to make sure also that you have a kind of a fundamental understanding. I have to mention, addiction as a chronic illness and give you some understanding of that. So when you're working with individuals who might need this type of service, you really understand what are you working with? What is this thing? What is addiction? Because it's not a lot of things that people think it is or what we see in popular culture. And it might be things that you haven't heard of before. So we want to understand that biological process of addiction, along with the behaviors and the emotions and the decision-making and things that go along with that. So really that process of change, we can all look at change. We can normalize that a little bit. Change is very hard unless you have figured out something that I would say everyone else around you has not, and you're perfect and you don't need to change anything. You've cracked the case, but change doesn't happen overnight. It is a process. It's incredibly difficult. If someone were to tell me to make a certain change in my life, I'm probably not going to do it if I'm comfortable. So if I'm uncomfortable, then I'll consider it. And even if I'm uncomfortable and I'm considering it, it's going to be a hard thing for me to do. So if the doctor speaks to me about my own health condition and says, hey, this is what you need to do to help yourself. And I'm like, yeah, I feel kind of cruddy sometimes and I understand what's happening and you're telling me this information and I just need to eat a salad for lunch every day. And then I try to do that forever. That can be very hard. And maybe the next week I'm back to eating whatever I ate for lunch. Or if I'm trying to exercise, maybe I'm back to a different routine or whatever it is you're trying to change about yourself. Just try to normalize that piece. That change is very difficult. It's even more difficult when you're talking about a chronic illness, when you're talking about biological process, which we all have our own biological processes and chemicals flowing through our brain. But with addiction, there's a very specific biological process that's tied into it that people are working against. So it's kind of like swimming upstream. And even if someone has been able to find that motivation and feels uncomfortable, so they want to change, it's still hard to do. So addiction is defined by the American Society of Addiction Medicine, talks about that chronic disease of brain reward. That circuitry involved with the brain is your reward pathway, and really we all have that. So anything you do that you enjoy, your brain kind of lights up because of the reward pathway and you feel pleasure. Or at a basic level, you might just feel okay because your brain's functioning. If we talk about the average non-addicted brain versus the average addicted brain, there's a different chemical process occurring for someone who has an addiction. You might even look at addiction as you talk about type 1 and type 2 diabetes. There might be someone who has a very strong hereditary pull towards, addiction because of that average addicted brain, because of the family lineage and what's been passed down to them biologically. There might be someone who uses enough substances during a long enough period of time, they actually alter brain process and function. So you can kind of look at it a couple of ways as far as nature versus nurture. Both of those can play a role, but the brain does have a certain response that ties into this addictive process. Whereas someone who has an average non-addicted brain, and I speak in those terms of averages because all of our brains are different, but that average non-addicted brain, you might think, oh, well, I can have a drink occasionally and that's fine, and I won't do it again for another week or a month or whatever it is. So why doesn't this person just stop that? That's a very simplistic way of looking at it, which does work for you, but it doesn't work that way for everyone, and we're all different. I like to use the analogy of we all look different on the outside, and we think, oh yeah, that makes sense. We're all different. Obviously, we're not all twins or triplets or what have you. So we all look different because we're different. With brains, people almost assume that every brain functions exactly the same. But it's that same thing that no two brains are exactly the same. But if you look at an average type of brain in any certain category, they're functioning close to each other, but they're still different. And brain's this amazing, fantastic organ that has all these things going on. There's no way that you're going to have someone sitting across from you with the exact same process going on within themselves and in their brain as you do. So back to that biology, nature versus nurture, that reward system, that pleasure pathway, speaking of that in a couple different terms, and then just understanding hedonic tone. So hedonic tone is what we all have as kind of our center. We feel okay, we feel normal. That's just kind of your regular average processing for someone who maybe doesn't have an addiction. And maybe someone who does have an addiction, there's just varied levels of what that hedonic tone means. So if we go back to that average addicted versus average non-addicted brain, someone who has an addiction, who has that addictive process happening, starts with a lower hedonic tone. And you may have heard people, and I've heard people say this to me throughout my career when I'm working with individuals who have addiction. Someone says, you know, when I used amphetamine, when I used alcohol, when I used cocaine, when I used marijuana, whatever it was, when I used this thing for the first time, I felt normal. I finally felt like, you know, this is what other people probably feel like all the time. I feel okay now. Now, me, someone who doesn't have an addiction, who hasn't been addicted to substances, I say, well, wow, if I would have used that, I would have felt horrible. I mean, I'm someone who's taken a pain pill after surgery and just been like, man, this makes me feel sick. I never want to take this again. And I barely want to take it when I'm getting through pain. There might be another person who takes it and they're like, this, I feel normal now. Like I feel okay. I finally feel like how I perceive other people feel. That doesn't mean you can't get high also on substances, but at a very basic level, it's completing something for that person as a chemical process for them to function and kind of feel balanced out. So there's something missing there with that reward process and how the brain lights up and how you even feel okay, and not just how you feel great or high or things like that. So this quote that addiction is a failed and doomed attempt to elevate and maintain adequate hedonic tone is something that I appreciate, this quote. And also, if someone is using substances for a very long time, they're actually raising how they feel, right? If you feel high, if you feel better, if you get, you know, use more and more and more and you build tolerance up to it, and then you stop using, your hedonic tone actually goes lower than when you even started. So then it's not even just the low level that you experienced previously, it's an even lower level. So over time, as you're getting used to not using a substance, you have to even figure out how to feel as well as you felt before, and then address how you might feel like the average person does without a substance in your system. So it's really kind of this uphill battle when you talk about someone getting sober and stopping a substance, that it takes time for their brain to adjust to not having those chemicals in the system. Then it takes time for their brain to adjust to how do they experience pleasure again? How does the brain respond to that when you're doing naturally rewarding things? If you're playing basketball, if you're, I mean, whatever it is, what are those things that you enjoy that aren't influenced by using a substance, spending time with family, et cetera, you have to find an adjustment there. So it takes time to really work through that. And it's a difficult process. So that's that kind of working upstream that I talked about. So with addiction, not only is all this stuff going on that we can't see, so a lot of times people, of course, with an addiction feel misunderstood or don't really know what to make of it themselves because they're just responding to what society says it is and how they might need to respond to it. There's also the social stigma and these names that come along with having a substance use disorder or an addiction to substances, names that I don't use that you might hear. I mean, I know people who go to AA who might refer to themselves as an alcoholic. And that's kind of a part of a culture there and where AA comes from and how people might refer to themselves. I'm not going to call someone an alcoholic or an addict or any of these other things. But when people self-identify and, you know, maybe they have a certain level of comfort with how they communicate about their own use, you know, that's okay. And that's up to them. But I'm not going to be labeling people as I work with them. It's still that people first language as you hear about in mental health. And it's no different with this, that I'm not going to label people, nor am I going to speak negatively of them. But society kind of thinks, you know, oh, people with addiction, like they're criminals and like they have to go to treatment and they drink coffee and smoke cigarettes and stand in groups. And like that's addiction and that's addiction treatment. And that's just not true. And there's reasons why people think that, which we'll address here in a minute. So what about other chronic diseases? I mean, there's other ones out there: hypertension, diabetes, asthma. I don't see a list of names that go along with these. And it's interesting because there's that overlap, you know, with addiction as a chronic disease, there's some overlap with criminal justice. That's just inherent in this whole thing because of certain substances being illegal. Using them, possessing them, whatever might sprout from that. I mean, yes, there could be a legal charge, but there are many people out there that we're not seeing on TV and lined up at treatment and referred to treatment, et cetera, who might even be your neighbor, that have an addiction. And it hasn't been identified because they're not talking about it. Because they think, if I say I have an addiction, I'm all these names that people are saying. Maybe I'm a criminal, maybe I'm gonna lose my kids, maybe I'll lose my job, maybe I'll be in trouble because I said this out loud. That really creates a barrier to people even identifying that there's this thing going on because not enough people are talking about it in terms of a health condition. And when you talk about relapse, which is another thing that comes up often with like, well, they just need to quit using a substance. Like it's that easy, it's one dimensional, just stop using a substance, which it's not, as I explained. But even then, they're judged for relapsing. Relapsing, in terms of addiction, sounds like horrible to people, and like you'll never change, you relapsed. When you're talking about any other behavior change, process change for ourselves, relapse is really just an opportunity to reassess how we're going about our change process. It's time to step back and say, what was working, what wasn't working, what should I try next time that's different than this time? Like, we've all had that happen. I mean, like I said, for my example to normalize change process as like diet and exercise, I do that, man, every 3 months probably. I find something that works, and then I get off track and I'm like, oh man, like I was doing well for 3 months, and then I readjust it, and then I find something that works, and I get off track. So for me, it's been this like ongoing process, with mostly up and then these dips that happen. But there's relapse that occurs with these other chronic illnesses, as we have listed here: type 1 diabetes, drug addiction, hypertension, asthma, whatever it is for that person's care plan to really improve their health and make the changes that are required for them to be as healthy as possible. Relapse occurs. But for relapse to occur and someone to adjust their plan so they can succeed long term, versus someone relapses and they return to use and they're back where they started and they're not trying to make a change, that's different and that's dangerous, right? But it also doesn't mean that person's lost in the process. It's just that's different than a relapse occurring. So we can't treat them as the same thing either. So when you talk about chronic illnesses in general, I've heard physicians talk about, well, diabetes is one that I've heard come up from physicians, and they're like, oh man, like there's certain things they say when they're describing this population. They'll be like, shows up most often when their symptoms are at their worst. They're not making these changes. Like, why can't they just make the changes they need to make? They keep coming in and they haven't made these changes. They haven't sustained these changes. They're not doing enough. They could be so much healthier. The provider's just talking about how frustrated they are. We're having these same conversations over and over. This person isn't managing their chronic illness how they need to, so it's not going how I believe it could go. And when you talk about substance use as a chronic illness, there's this other layer, and it's that intersect with criminal justice. I will tell you that one of the things that comes up here, and I'm probably jumping ahead of my slides, so I'll just have to repeat it again in a little bit, but that intersect with criminal justice is really that 1 out of every 10 Americans aged 12 and older could be diagnosed with a substance use disorder. 1 out of every 10 people who could be diagnosed are actually showing up to treatment centers. It's actually 11%, but let's say 1 in 10, so 10% of the people who need it. There's 1 in 10 of those people who might need it. There's 1 in 10 of those people who are showing up to services. And when you look at who's actually in treatment, 2/3 of the people actually in treatment are either self-referred or referred by criminal justice. And less than 7% of those people have been referred by healthcare. So when you talk about the stigma around, oh, they're criminals, there's very few people who actually need the service that are showing up. And the people who are showing up are often involved with criminal justice. So a lot of stigma just pulls from that, because those, these are the people we're seeing in treatment centers, but they're a very small part of the whole and all the people who might need the service. So when you talk about substance use disorder, I hear people talk about like, I'm addicted to caffeine. And you're not. So that wouldn't be the right way to say it, but you might be physically dependent upon caffeine. So if you drink a lot of caffeine and then you can get high on caffeine, there's caffeine intoxication, there's caffeine withdrawal. Those things don't mean you're addicted to it. They mean there's some physical dependence. You can have physical dependence on medications that you take as well. Obviously, there's some prescribed medications that get all the way into opiates and things like that, but even like allergy medication. I know someone who, when they take allergy medication daily throughout the year, if they miss a dose, 3 o'clock the next day, they feel horrible. So their body is withdrawing from this medication and trying to find a balance as the medication leaves their system. So these are actually things that we would diagnose. So you've got, I won't read through all of them. Tobacco use disorder on here is actually the thing that kills the most individuals. Health conditions related to tobacco use is killing the most individuals in mental health services and substance use disorder services. More than any of the substances they're using the most, when you talk about IV drug use and opioids even, and all of these things, there's been more deaths because of tobacco use disorder. So that's something at our treatment centers we treat as well, and we provide nicotine replacement therapy to all of our patients, and detox residential and outpatient services. We're not having smoke breaks. We're not practicing this process of addiction in the brain with tobacco, which is most likely to kill the person, than the substances we're treating during the sessions. We're treating it all together and talking about it all together, because that's the most important thing for us to do. And research has shown that if you address them both at the same time, you actually have better long-term outcomes. Even though the first thing people say is, oh, don't take their cigarettes away. but it's just, I can't in good conscience do that, because we have to treat all of these things that are going on for someone and understanding the process of the brain and how we might affect that through our treatment. Diagnosing addiction, as I mentioned, caffeine wouldn't fit into this when you talk about mild, moderate, and severe substance use disorders. For any of those substances listed, you're looking at number of symptoms present. So the bottom two, as tolerance withdrawal might exist, that's not a thing with caffeine. That's not something that's been given a caffeine use disorder label. If you're taking a medication as prescribed, that's not an addiction. That's not a mild substance use disorder. That's just physical dependence. So tolerance and withdrawal are the physical dependence components of addiction, but there's all these other things listed. So it's really continued use despite negative consequences. So if you're experiencing negative consequences because of substance use, and then you keep using it, and more negative consequences, and you keep using it, and more negative consequences. And there's all kinds of things that can be those negative consequences in your life, but it's really that continued use despite the negative consequences that tie into the diagnosis of substance use disorder. Typically, when you're looking at moderate substance use disorder or severe substance use disorder, that's more of what you might call addiction. It used to be called like substance dependence in the old DSM, and the mild category was called substance abuse. We don't really use that same language anymore. So if I were saying substance use disorder, mild, moderate, or severe substance use disorder, or I were saying addiction, mild substance use disorder isn't necessarily addiction, in that maybe someone who has a mild alcohol use disorder could use socially again someday, because of how the process affects their brain and how they're able to maybe not have it be in such a severe category. That's possible. Once someone really falls into the moderate and severe, that's a little trickier and more dangerous to ever say that that person's going to use socially. That's probably something that they should never be using again. So it's really understanding that person to person. Where do they lie in this? What kinds of issues has it caused? How big is it for them? And is there a way that they can function, as some people might say, well, I'd like to drink, I'd like to have a drink once a month, or be able to go to someone's birthday party and have a couple drinks. Maybe, I can't judge each person without knowing them and working with them individually, but I will say once you get to moderate and severe, that's a little trickier. So as I mentioned, the data here that 1 in every 10 Americans over the age of 12 could be diagnosed, but 11% of those with an addiction receive treatment. So getting back to the why is this, I jumped ahead. We're seeing a lot of referrals. Most of the referrals we get are coming from criminal justice. And that's something. I mean, things have gotten severe enough as you look at diagnosing addiction. Things have gotten that severe from continued use that there's been legal consequence that's happened. So now they're told to go to a treatment center, and it's essentially like, stop using the substance, don't get in any more trouble, check that box and show us your certificate. But there's more to it than that. It being a chronic illness that needs to be managed longitudinally, so long-term, over time. You can't just say like, I've done that now, I stopped, things are good, because this process still exists for you. So you have to manage that brain process somehow. It can't just be that like, I've conquered this and now it's done. And it's not the same for everyone as far as how you manage that. And some people use AA and NA. I do believe there should be a stronger element of follow-up care in healthcare when you talk about addiction treatment, and some funding mechanism to make sure that there is follow-up care, because plenty of people finish and like, yep, I've got this. And then a year later, they're back at the treatment center, or 2 months later, they're back in detoxification. There's got to be some mechanism to really stay connected and check in, versus like, well, good luck, tell us if you ever need us again. I will tell you that if we did that with diabetes, that would not fly. No one would put up with that. If you said, I've been treated for diabetes, I've made some gains, I think I'm doing a little bit better, and the doctor said, well, good luck with things, it seems like you're doing all right now, so let's not schedule a follow-up. We wouldn't do that. We shouldn't do that with addiction either. So how can we do better as a system? How can we do better as individuals? Accepting addiction as a disease that requires healthcare and chronic disease management. Addiction isn't a fringe diagnosis. If you think that, you're kidding yourself. And if the system doesn't believe there's more people out there that need the service that aren't getting the service, then the system's wrong. So the data would show that there are plenty of people out there who need the service. In fact, if everyone who needed the service showed up tomorrow, our system would not be able to manage the number of people who showed up. I think that as we move along here, it's really going to happen in steps. But I think avoiding addressing the issue isn't going to get us anywhere good. It might just stall us out where we're at. And it's not going to help people get better and healthier and be able to feel comfortable bringing up their substance use or the health condition that's occurring. And there are some people who use substances who also, may commit crimes. Possession of a substance when you're addicted, that's a little harder for me to say like, oh, they're criminal. If someone commits a crime, a robbery, they might really need housing or income or food, or maybe they are supporting their drug use. But even then, what do we do to treat this health condition that might be at the core of these things occurring? There is a decision process. They have decided to do certain things, and that's that criminal component for the crime as the crime's defined. But it doesn't mean they're just a criminal, and it doesn't mean they don't deserve health care. And those are actually the individuals we're seeing the most, but there's a whole lot more individuals out there who aren't committing crimes who are using a substance. Or maybe if they were caught with the substance, then they'd be called a criminal because they have the substance, but otherwise they're living their lives and they're out there and they're not getting the right service they need. Asking the question as far as someone coming in through any setting, we need to understand how we screen for that, how we ask about it. I think it were pretty crazy if I went to the doctor and they didn't, take my weight and my blood pressure and my temperature. I think it's pretty crazy too that if we go through a healthcare setting, we're not asking, more often asking about substance use as it occurs, because how are you really able to treat any specific health condition if you don't understand someone's relationship with a substance or substance use that's affecting their process, or if they have, that average addicted brain, that process going on for themselves. We need to understand these things. We need to normalize it by asking. We need to then know what to say back to the person if they say, yeah, I'm struggling with this, I'm not sure what to do. Some people are afraid to ask the question because they're like, well, if I ask and they tell me, then it's on me to tell them how we can address this. And I don't think there's anything available for them, or I don't understand how to access that system of care. So there's all these other things that might sit out there of why the question isn't asked, but we do need to ask the question. We then need to know what resources are available. We need to coordinate care and make sure it's not just like off on this island hidden somewhere that someone accesses treatment, because there's a lot of misinformation about addiction treatment that starts with like that perception of what addiction treatment is as you drive by, and it's like smoking and coffee breaks and people who are sent there by a court. It also might be that someone feels like they're going to be locked up for 60 days because they said that they're struggling with substance use, which also isn't true. There can be involuntary admissions, but I don't remember the last time I saw that at our treatment center, and we have a 30-bed adult facility in Salina. But it can occur if things have gotten dangerous enough and it's really, to protect the safety of them and the people around them. That can happen. I rarely see that happen. It's definitely not going to be the result of someone saying, hey, I really need help with this, and they're walking into your office to get an assessment. I'm not going to involuntarily commit somebody through that process. Medication is valuable, so medication-assisted treatment, but someone getting assessed for maybe the first time to understand what's going on with their substance use and the rest of these facets of their whole health, who hasn't been to any kind of treatment setting, there's thoughts, there's behaviors, there's emotions, there's things that they can talk through and work on and should be talked through and worked on. There's also medication that could help the biological process. Not every person who's trying to make this change and not use substances needs a medication, but it might be that at some point it's the appropriate thing for them. But it doesn't mean that you shouldn't work on these other things. It's kind of that there's not a magic pill for anything. If I went in and spoke to a therapist about my depression and the depression were severe enough and I weren't making the gains that I needed to, they might say, there's this medication that could kind of help you with that process too, while you're also working on these other things through talk therapy. When you talk about medication-assisted treatment, it is that treatment coming to counseling sessions plus medication together. If someone takes the medication long-term, which is fine, there's a lot of research out there around how people can succeed long-term by taking an opioid agonist, even if they're taking Suboxone long-term, and it's kind of meeting that need of an opiate at a very low level in their brain, and everything else in their life is good, and they don't meet criteria for a substance use disorder, because the only thing that's there with this prescribed medication is tolerance and withdrawal. And no longer are you seeing that there's these other negative things happening in their lives. They could take Suboxone for a very long time, and even though someone says, well, that's an opiate you're on, they're actually functioning very well. Now, as someone finishes treatment and they continue with the medication long-term, or if they want to get off the medication in 3 months or 6 months, that's also up to the patient and the physician to decide. That's okay too, but someone could be on a medication long-term and be finished with their treatment component because they've gotten all those pieces that we're trying to give to them as they're working through how to manage it long-term. Treating the biology, psychological, social, and spiritual components. So people are dynamic, addiction is dynamic. We can't treat it as one-dimensional. We can't treat individuals as one-dimensional. We have to address all of these things so we do the best job we can providing treatment. So when you talk about people coming through healthcare settings, and I say, some places are asking the question, many places are not. If you really dug in primary care, in the bottom left-hand corner, it shows that 23% screen positive. So screening positive for moderate to high risk substance use. This isn't diagnosing addiction, as I talk about the 1 in 10 ages 12 and older. This is the individuals coming through primary care, are answering questions about their use, and moderate to high risk substance use is occurring for them. They would need to, of course, have an assessment and understand if there's a diagnosis there, if we're going to diagnose a substance use disorder or if addiction is present. The upper right-hand corner is showing acute care settings such as hospitals that if we're talking about it and we're documenting it, we're putting it in the record where you can track the information, 17% leaving acute care with a diagnosis. So that would be addiction being diagnosed. And in some settings, this information comes up if there's a positive blood alcohol, if there's a positive alcohol urine drug screen or a urine drug screen positive for any substance. You might find out that way if you're screening. You might find out that way if you've worked with the person many times. You might find out that way. But even then, does it get documented in the record in a way that is searchable later? You could actually query the record and find, are there diagnoses and what percentage of patients? Some places aren't necessarily putting that in the record. It's just kind of this footnote that occurs somewhere in the content of a note. So data is also a difficult thing in healthcare settings if you're not asking the question and putting it somewhere that can be reported on later. So as we get into healthcare setting, or as you're, visiting with individuals in their homes, it's just really understanding, are we screening so that we can ask questions and identify if something's going on? It's not that you're like catching someone or that they have to go to treatment if they say there's something going on or anything like that. It's just that we need to be opening a dialogue around it. And actually the most important thing when you open a dialogue is building a rapport. Because if you can build a rapport with someone and they trust you and they know you have good information and they know they can ask you when they want more information and they like visiting with you, that's a great thing. And that's not something you want to give up. Now, if someone comes to you or you like turn them off to the process and you're like, well, you have an addiction and you need to go get treatment. Now, I may not come back and visit with you anymore because I was really turned off by that interaction, because maybe I don't think I have an addiction. Maybe I don't have an addiction. Maybe I'm misusing substances in some way, or maybe, I drank a lot last weekend, but that's not usually what I do, or whatever it is. Leave that for further down in the process. But if you turn someone off to the conversation about it, they may not talk to anyone about it again. They most certainly might not talk to you about it again, but just really, we need to talk about it and open a dialogue. And if someone comes back to you and you talk about it 20 times, and at some point they want some help and it's a gradual process, that's a much better thing than trying to push it all on them at once. And maybe it's not exactly what they need, but you think it is, and they don't come back. That's the worst thing, because then this person's out there, invisibly going about their lives, and no one's around that really has the information that could have benefited them. So stay engaged with people. Coordinating care, making sure you're engaging healthcare providers in the process, I think is a very important thing. As we partner with some clinics across the state, we want to make sure we're part of a care team, which ties down below when you talk about having a team-based approach. But, not any one setting. I know some settings do more than other settings, but like CKF, we primarily treat substance use disorder in adults. Now, we're not a community mental health center, and we're not a housing agency, and we're not ... a primary care center, and all these different things. We're not an acute care. We don't have psych residential beds. So there's things that you need the system to really address the 8 dimensions of wellness. When you talk about the layers of people and all of their health and all the things around them in their environment that might help them, you need to coordinate with others, because since addiction isn't as simple as quitting a substance and that's all there is to it, there's all these other components in people's lives that might go along as part of this systemic component, right? So if I'm struggling with custody of my child, or joblessness, or housing, or my mental health, or my substance use, or ... that's a whole bunch of stuff. So if we just try to focus on one thing, and we don't also coordinate care to take care of these other things that are causing stress, might, return to use because someone's trying to feel okay through the process. So they're going back to kind of old behaviors and habits to cope. You're not doing, justice for that full picture. So make sure you coordinate care and you're getting the right pieces connected to that individual. Getting an assessment done in Kansas, a licensed addiction counselor completes an assessment. That assessment, of course, we have to have that record for the state as a licensed substance use disorder provider. We have to show that in the record as payers interact with us and we're getting payment from insurance. There has to be an assessment that ties to the recommendation for care. And licensed addiction counselors could be any of those letters I listed there: licensed addiction counselor, licensed master's addiction counselor, a licensed clinical addiction counselor. Really, those are the individuals who have special training. There might be dually licensed individuals that have another master's level license to provide mental health care, and they have a LAC or an LMAC or an LCAC. So our staff are those types of staff who are doing the assessments. Treatment, there's a couple of things here. Someone might get treatment from a licensed addiction counselor, and in its traditional sense, that's typically what you're seeing. Kansas certified peer mentors, however, are providing more and more care, which I think is a great thing because it's individuals who have received a certification from the state. They've completed 2 trainings. They're actually in their own recovery, sustained long-term recovery. To get the training, they have to have had experienced substance use themselves and been sober a year. And different treatment centers have other expectations. I know in the past, which I think there's been some exceptions, we used to say, okay, someone who's been sober 2 years and has this would be someone we could hire. Of course, there's supervision in place, and our peer mentors and our counselors operate as a team at our center. And I think you often see that when peer mentors are employed and providing services. And then that team-based approach, making sure that we're working together, whether it's within the agency or with other agencies outside of us. How do we stay connected on the same page so we're not speaking completely different languages and don't really understand the full picture? It's important for us to know that we're actually hitting the nail on the head and we understand what's going on with the patient, and as well as the patient being part of the team. We need to get feedback from the patient, even when it comes down to the patient's experience in our services, and if the patient feels like things are going well and if they're progressing, we need to understand that from the patient as part of the team. Follow-up care, which is often lost in addiction treatment, it really comes down to a funding mechanism, making sure that that's paid consistently, but we need to make sure that we're following up with patients on their care. So traditional services that you've probably heard of, detoxification, typically a 3 to 5 day stay if someone's really struggling with continued substance use. Now, at our treatment center and many treatment centers across the state, detoxification is a really first come, first serve. There's funding for it from the state. They will be able to get in and get the service. If someone has been smoking marijuana, as far as the withdrawal process in the short term, it doesn't quite meet the criteria for someone to get a detoxification stay covered. Because marijuana stays in the system so long, it's really an elongated process of withdrawal that does have actual physical dependence components and withdrawal symptoms that happen, but it doesn't happen in that very short-term time frame as like someone having alcohol leave their system or opiates or what have you, these other substances that are out there. It's really 3 to 5 days is based on the substance they've been using, how long they've been using, and how long it takes monitoring them and helping them get through that process in a comfortable way. And then maybe with opiates, you're utilizing like a low-level opioid agonist to really help level that off so they don't feel an immediate drop, which a lot of times with opioid use disorder and someone quitting an opiate, they feel like they might die. They feel horrible, and you can't disagree with that. Now, not likely they're going to die if they're detoxing off of opiates. Now, with alcohol, they might. With certain substances and how they come out of the system, alcohol use disorder and withdrawing from alcohol, or if you're withdrawing from alcohol and opiates, that's a really scary thing. If someone's withdrawing from a stimulant such as amphetamine, or they're shooting up certain drugs intravenously, that can be a very horrible feeling process. But there's a large risk with someone detoxing from alcohol that you have to watch out for, which can also include seizures and their body really struggling with how quickly it's coming out of their system. So that's something to watch out for in detox settings, and the stay's typically 3 to 5 days. And there's different levels. Medical detox, usually that's a hospital setting. Subacute detox can occur at a treatment center if you have nursing staff 24/7. Social detox is monitoring patients, and nursing kind of comes in and out of the facility. So you don't have a nurse there all the time, but if someone needs to get to the hospital, you do that. So there's different levels of detox that might occur, and sometimes insurance dictates what the insurance is going to pay for when it comes to detox. Intermediate residential, the maximum stay we're seeing these days is about 28 days. Used to be longer. I think over time it's kind of focusing on, how can you get a good service and good outcome and not maybe insurance companies spending so much on going to a bedded facility or a residential facility. 28 days is what we see. Certainly you can go to private settings and pay a lot of money to stay a very long time. But our focus with our 28 days is do the best with the time we have, and then getting them connected to that next service as a step down level of care. Because when someone's leaving a residential setting, you're then looking at an intensive outpatient setting, and then you're looking at an outpatient setting, and you're working down from levels of care. So there's transition in place. If someone just goes to residential for 28 days and then returns home, that can be a dangerous thing because they haven't been quite ready where they need to be to address the environment that they're going to go back to. And they still have some other things to work on. They still might have post-acute withdrawal symptoms that occur for a period of 90 days. There's a lot more things that they need to work on managing as they get back into their lives. And that's why there's these step-down levels of care. Someone comes from a residential setting to an intensive outpatient setting to an outpatient setting, et cetera. Reintegration, there could be a lot more reintegration facilities. That's a great thing where people can get treatment and stay at a place and also start getting a job in the community and start working back into the environment of the community as it exists for them. We have a house women's program where they receive intensive outpatient. They stay at the house program at CKF Ashby here in Salina, and they can also have their children with them. There's some other designated women's programs that operate like that across the state. There's information on the state's website about those programs. So that's a good thing. There are some for males, but reintegration could, there could be a lot more. There's also some Oxford houses and things like that where people might stay at an Oxford house while they're getting treatment somewhere else. The Oxford house isn't part of the treatment center, but it's a sober environment where they can stay. So Oxford houses are another good way for people to have sober living while they're getting treatment. Intensive outpatient is dictated as being 9 hours per week, 3 hours per day, 3 days per week. 3 hours in a group is a long time, which someone who's really struggling, who's able to get to those groups and receive that, probably really appreciates it. Some might say, well, I've been doing that for a few weeks and now that's just a lot of time to give each week. And it's maybe not a lot of time when it's your life depends on it, right? But we really can't challenge that structure because it's dictated that it has to be 3 hours per day, 3 days per week. Within level 1 treatment, which is outpatient, that last level I listed, typically it's 6 hours per week and it's 2 3-hour groups. Sometimes in a very small office, that might be because patients are actually attending 2 of the 3 days with the patients in intensive outpatient. So they're still staying connected to that group they were in, but they're coming 2 days a week instead of 3. But there's a lot more flexibility in outpatient or level 1 treatment because you can have peer support built in. You can do individual sessions or you can do shorter group sessions. That would be less than 9 hours a week because intensive outpatient is that 9 or more, and level 1 outpatient is less than 9. A lot of times I see 6, but it could be shorter groups. It could be shorter groups more often throughout the week. So you can kind of play with that a little bit, and payers are okay with that when you're getting reimbursed by insurance. So with all that being said, why wouldn't we just do the traditional services? Why don't we just stick with that, right? Well, it goes back to these things that I'm touching on before. There's a whole lot of reasons to be untraditional. It's because we're not doing a good enough job. We're not doing a good enough job identifying, getting patients connected to the service they need, and being available where people exist. There's plenty of barriers. Even if someone is being asked the question and connected, there's plenty of barriers to getting to physical treatment settings. So CKF has had physical treatment settings in at least, 2 or 3 places. And I've been here 10 years and CKF's been around since 1967, but we've had a few offices that just didn't make it. Well, the reason is it's expensive to have an office, the office itself, the staff, the utilities, all these things. And then you have to have a certain volume of patients, and not just a certain volume of patients there on a regular basis, a certain volume in intensive outpatient and a certain volume in outpatient, and a certain payer mix. So you have to have different insurances connected to the patient. So you're getting paid enough to keep providing the service long-term. And what I've seen in some of our smaller communities where we had offices is we just couldn't pay the bills. We were losing money month after month after month. So you're trying to do a good thing to bring a service to a community, but it doesn't mean that you're going to be able to sustain that long-term. And I've seen that happen a lot. So CKF, not one of our strategies to open physical locations across the state. I think used to be one because it's like, oh, to grow, you open more physical locations. And for residential settings, yes, you would need physical locations if you want detox, residential. If you want to do reintegration, that takes physical settings. But even when there is treatment in someone's town, they may not be able to access it. They may not be able to get time off of work. They may not be able to risk not having the money that comes through their job. They may not have childcare. They may not have a car. They may not have a bus they can ride to get over there within the time that it's offered each day. There's all kinds of reasons someone who lives in a town that has a service or a city might not get that service. So just the note here that we're still not meeting the need. There's all these individuals out there who need the service, and we need to create more touch points. And talking to all of you, you can also be those touch points. It doesn't just have to be criminal justice. It doesn't just have to be healthcare. It doesn't just have to be friends and family, or wherever people exist. There need to be touch points where we can talk about substance use disorder and what's going on with their substance use and try to connect with them around that and get them the right service. So Now I'm getting closer to the end of my time. I just saw a message pop up, but I think we're going to manage questions at the end. So if that was a question, we'll be looking at that as we finish up here. CCAF has been expanding telehealth treatment. So what we did, just to dig into where we started with that and where we're at, telehealth treatment started for us with our opioid grant in 2017, and we started support groups because we were actually we were covering 65 counties in Kansas, which is really central to Western Kansas. So that whole chunk of Western Kansas was really where we were offering services with opioid grant dollars. And we saw through that plenty of people didn't have treatment options. So we started support groups with our peer mentors. And that was a really good thing for people to sign into, and they valued it a lot. We could also pair with physicians and prescribers and offer MAT, and they were getting something. Even though it wasn't quite the treatment that we typically gave, they were getting something so that we could stay on track with getting them services. We started working with Kansas Connecting Communities in 2019 to offer assessment and treatment to pregnant and postpartum women via telehealth. I'll talk a little bit about what those services are so you can actually utilize those services. If you're in Southeast Kansas, and I know they're trying to spread it to other areas, but if you're saying, oh yeah, I worked with pregnant and postpartum women who might need mental health services, who might need substance use disorder treatment, there is a great thing going on there with KDH&E, KU, Wichita State, CKF to get patients connected to the right service if they fall in that category of pregnant and postpartum. We started clinic partnerships to include the ones listed there. I think there's another one we're working on right now, and we're looking to expand that further so that we really can help tighten up the screening, the recognition, the referral process, and get services connected directly to people in their homes so they can get assessment and treatment from their homes, that they don't have to be at a physical treatment setting to get that. They can sign in and get that directly from us. There are other treatment settings, especially right now in the context of COVID-19. As I mentioned below, all of our services right now are telehealth. So not just as I refer to CKF telehealth addiction treatment and what we're doing to spread that service that we started working on a while back. Right now, all of our services are via telehealth. And depending on where we're at with COVID cases, right now, everything's telehealth and no one's able to come in for outpatient services. And the next tier down, when we're in an orange tier based on data, we have if people have to come in to get a service, we do it that way. When we're in the yellow tier, there's hybrid groups and people can attend in person, but also have some other members signed in on the screen to attend at the same time. We even had someone from Missouri call us a couple weeks ago to get into our telehealth services because they had heard we have them and we do a pretty good job. So there's all kinds of things happening right now with telehealth. And it really starts with, someone saying, oh, well, did they get an assessment yet? And you might hear that. But getting an assessment from home, is easier than ever right now. And because of COVID, you could actually do that telephonically and not just televideo. So if they were just able to connect on the phone, they might be able to get an assessment from where they exist. And the paperwork process, each agency probably has their own process. We send out forms via secure email, and they're able to complete their forms from home as well, their admission from home, and their treatment from home. So the treatment that we've been building with clinics does have the one-on-one sessions with an addiction counselor. It does have one-on-one sessions with a Kansas certified peer mentor. There are daily sessions, so we're not sticking to like that 3 hours, 3 days a week. Really daily sessions, 1 hour group sessions, 5 days a week is where we're trying to extend more contacts throughout the week instead of just connecting for a lot of time on 3 days and then you're out there on your own for 4 days. It's really trying to connect with people throughout the week and give them more support more often. Crisis intervention is a component of that. So if someone needs to get connected to their counselor right away, they can do that. If they need to be assessed for a higher level of care, if they need to just talk about what's going on and what they're experiencing in that moment, they can reach out and get that. We don't have 24/7 staff. We do with our residential setting, so people can call here and always talk to someone, but it might not be their assigned counselor, it might not be their peer mentor. What we try to do with the MyStrength phone app is via that app, people can get evidence-based curriculum that they have access to in between sessions. So we need to close gaps. We need to do that in a lot of ways. So what we're trying to do is close gaps between treatment sessions so they have something they can utilize. And when we talk about referrals, we need to close gaps there so that we don't just let someone hang out there without a referral. Or if a referral is made, we actually try to assist them through that process to close the gap. So anytime you're able to close gaps as you're navigating healthcare and getting people access, making the phone call with them, getting it on the calendar with them, supporting them to do that next thing, that's a good thing versus like, well, I gave you that card. Did you ever call that number? People probably aren't going to call the number because it is stressful to engage with a new service, with a new person, address something maybe you've never talked about out loud, to go from someone I trust to take the card they gave me and then call someone I've never spoken to before. I'm probably not going to make that call unless something's really motivated me to that point. But I would say the minority of people who are given that card are going to make the call based on having that card in their pocket. So our brochures that we've given out, this is just kind of the front of a trifold, but patient feedback, we've gotten really good feedback about the service. There's always going to be things you can fix. I'm not going to say like, yeah, no one ever says that it's not the right service for them. Certainly people say it's not the right service for them, but the majority of people are saying it's a very good thing. It's helped them a lot. If they didn't have it, they wouldn't have anything else. That even if they stop the treatment service from us, they still want to stay connected to the people they met through their telehealth treatment group so they can build their own support network moving forward. Those are all great things. Our Pathfinder Recovery Center has some telehealth services available 5 days a week that people can sign into for free and really get that support from each other and from peer mentors Monday through Friday. So there are free services we have available as well, not just these telehealth treatment services. And I can get some brochures out for that. If you want access to those forms, I can send it to the staff who got me scheduled for this presentation. So there are things out there, even if they don't want to get an assessment, there are things people can connect to from their homes virtually and get some support. The Kansas Connecting Communities, as I referenced just a little bit ago, is that partnership to address the health and well-being of pregnant and postpartum women. It is a HRSA grant that flows through KDH&E, Kansas Maternal and Child Health, WSU, KU's Project ECHO, CKF work on this together. It's not just about substance use disorder. There are mental health screening and mental health service components to it. But I'll tell you what CKF helps to provide through this initiative is that we help locations tighten up their screening process. We train them on how to then refer patients to a telehealth assessment, to telehealth treatment. If the location wants a physical space in their building for a telehealth assessment to happen, we can work on that with them. If they say, yeah, the patient can get assessed from home, we can of course provide that as well. That access to care piece, we will use that assessment, that information to help navigate the treatment structure in Kansas so that we can call facilities if they need detox or residential, get them lined up for a start date, of course, get a release signed with the patient in order to communicate that information to other facilities. Or if they're wanting to attend the outpatient service and that's the appropriate service for them, we can do that as well. There's a psychiatrist available. So if pregnant and postpartum women are needing psychiatry and it's not available in their area, we do have a psychiatrist that actually is connected to CKF. So the grant dollars pay for that psychiatrist to be scheduled with the patients. I think right now we have time held every Monday, but there's actually more hours available and we can expand that. If enough people are needing access to that service, there's more dollars to support more psychiatry via telehealth for patients who might need it. There's a consultation line, so staff or individuals, if you have questions about someone's mental health or their substance use disorder or substance use or questions about care, whatever it is, there's a consultation line that can be used and it's active right now and it has been for quite a while. It goes through one of our staff who's duly licensed as a qualified mental health professional and an addiction counselor. And then if that call needs to go to a psychiatrist because it's about medications or something like that, we can connect the caller to our psychiatry staff to talk about that. So that would actually be like a provider consultation line. A nurse, a physician, you all, whoever it is that says, hey, this is what's going on. It is specific to pregnant and postpartum women and mental illness or symptoms of mental illness or substance use disorder or some substance use occurring. If you have questions, you can call this line and get an answer. It's Monday through Friday, 8 to 5. You get a call by the next business day at the latest. Typically, it's the same day. If it's over the weekend, that will be something that they'll have to call back on Monday. So that's the structure for it. But it's been a really good thing. And then there's also trainings available through Kansas Connecting Communities about pregnant and postpartum women and their unique health needs. So that's been a great thing that started in Southeast Kansas, and I know they're trying to expand to other areas. I would say if you have questions about it, let me know. You may have met other people who've spoken about it, but they're, the staff I've worked with through KU and KDH&E are very excited to try to get the service to the people who need it. So if you're like, oh, you said Southeast Kansas, I won't even check on it, let me know because they're trying to connect to other communities and I have seen them connect to other communities through this initiative. So it's been a very good thing. And this is the page where I hold for questions. I do have my email address up there, which is the best way to get a hold of me because I check my email 7 days a week, but may wait till a weekday to respond. But if you email me, I will get it and I can answer your questions. If you have questions now, though, I think someone's going to help me facilitate that process if there's some questions that have built up on the question board.
Shane, you just have one question that's waiting for you, and it says, what opportunity is there for telehealth type addiction treatment?
For telehealth type addiction treatment?
That's what the question says.
Okay. I would say through CKF, if someone called our facility and said, hey, I want to complete a telehealth assessment, it doesn't matter where they exist across the state of Kansas, they can get an assessment from us, and we'll work that out with them to get it scheduled from their home, get them their paperwork to complete via email and Adobe Sign and go through that process. So we're not the only ones who have telehealth services right now. I think plenty of treatment centers have extended their services to include some telehealth components. But because we are a substance use disorder facility, we don't have catchment areas like mental health centers. Anyone across the state could call our facility and say, I want to schedule an assessment to see what's going on with my substance use. And if they just want an assessment and they don't want treatment after that, that's up to them. No one's going to force them to do treatment. But if they're wanting to follow up on treatment, we can get them connected to a service. And if we need to refer them to an in-person provider after that in their community, we can do that as well. No one's being forced to attend telehealth services if they don't want that service.
And another participant really likes your presentation and was wondering about your ability to give this information to another group, but I'm assuming if she reaches out to you, you
Okay.
can answer that specifically about what you can do from here forward.
If I could just get an email from that individual or anyone else has questions, then I'd be happy to follow up.
Awesome. And if anybody else has any questions, put them in the chat. Thanks, Christina. If not, I'm going to stop the recording.